Okay, we're going to be continuing with the spinal nerves. So again, we have 31 pairs of spinal nerves. And if you do the math, we're looking at 8 pairs of cervical nerves, 12 pairs of thoracic, 5 pairs of lumbars, 5 pairs of sacral, and 1 pair of coccygeal. So 8 and 12 is 20, plus 10 is 30, plus the 1 coccygeal is 31. And these are mixed nerves because they're sensory and motor. And again, just to review what we covered in our other video, if we look on the right-hand side, we have cervical plexus, which is C1 to C5, and the biggie there is the phrenic nerve. Keep in mind that between C1 and C2 is the medulla oblongata, and that the first vertebra is called the atlas, or C1. But we have 8 pairs of cervical nerves, although there are 7 cervical vertebrae. Again, the cervical plexus is C1 to C5, whereas the brachial plexus is C5 to T1. That is C5, C6, C7, C8, and the T1 nerve root. The terminal branches of the brachial plexus are the musculocutaneous, axillary nerve, median nerve, radial nerve, and ulnar nerve. When I think of the musculocutaneous nerve, I think of mostly the elbow flexors, like the biceps brachii, the brachialis, the coracobrachialis. When I think of the axillary nerve, there's only 2 muscles that come to mind with the axillary, and that's the deltoid and the teres minor. When I think of the median nerve, I think about 90% of the wrist flexors are median nerve. There's only 1.5 muscles of the hand that do not get median nerve innervation, and that is the flexor carpi ulnaris and half of the flexor digitorum profundus. Everything else is median nerve, but that 1.5 muscle, the flexor carpi ulnaris and half of the flexor digitorum profundus, get ulnar nerve innervation. And then the radial nerve goes to everything that deals with extension. Elbow extension, wrist extension, finger extension, anything that deals with extension of the upper extremity from the shoulder down is going to be, from the elbow down, including the elbow, is the radial nerve. Keep in mind that the thoracic nerves, the 12 pairs, there is no plexus. A plexus really means like a braid. It's like taking someone with long hair, like my daughter has long hair, and they could be braided. That's what a plexus is. But instead, in the thoracic region, we have intercostal nerves, the nerves that go to the intercostal muscles between each rib. In the lumbar region, there's the lumbar plexus L1 to L4. Lateral femoral cutaneous nerve we spoke about with that condition called meralgia paresthetica, which is numbness and discomfort to the front or the anterior lateral thigh. The femoral nerve goes to the quadricep muscles, and then the obturator nerve goes to all of the adductors, like adductor longus, adductor magnus, and adductor brevis. Then we have the sacral plexus. Sacral plexus is L4 to S4. The big nerve there is the sciatic nerve, largest nerve in the body, and it's really made up of these two, the common peroneal and the tibial nerve. When we look at the coverings of nerves, very similar to the different layers of muscle, how there was a endomysium, a perimysium, an epimysium. Here, when we talk about nerve, we have an endoneurium, a perineurium, and then an epineurium. So surrounding each axon is going to be endoneurium. Then when we take a group of those, that surrounds it like this, that's the perineurium. When we take a bunch of these perineuriums, right, this is also, each of these is a fascicle, and we surround those all the way around. That's the epinerve, and that surrounds the entire nerve. So endoneurium, perineurium, and epineurium. Shortly after passing through its intervertebral foramen, a spinal nerve divides into several branches known as rami. So let's take a look at a dorsal ramus and the ventral ramus. Dorsal ramus is right here. So this is all sensory. And it also goes to the muscles of the spine that we can see here. The ventral rami is here. Now, ventral rami, ventral is always motor, dorsal is always sensory. These ventral rami, the ventral rami of C5, C6, C7, C8, and T1 make the brachial plexus. The ventral rami of C1, 2, 3, 4, and 5 make up the cervical plexus. The ventral rami of L1, 2, 3, 4 is the lumbar plexus. The ventral rami of L4, L5, S1, 2, 3, 4 is the sacral plexus. All right? Here's the spinal cord. Here's the dorsal root ganglia. We can see that swelling right there. Here's the meningeal branch. Here's the subarachnoid space that contains cerebral spinal fluid. Here's the epidural space that contains fat and blood vessels. Here's the dorsal root. Here's the dorsal root ganglia. Here's the ventral root. And these rami communicantes have some autonomic relationship. So the spinal nerve is formed from dorsal and ventral roots. The dorsal rami supply the skin and the muscles of the back. The ventral rami form the plexus that supply the extremities. And then the meningeal branch is going to supply the pia mater, arachnoid, the dura mater, the vertebrae itself, and the blood vessels. So the plexus is the joining of the ventral rami, and we have them in the neck, in the arm, the lower back, and the sacral. And remember, there's no plexus in the thoracic region. Instead, here we have intercostal nerves that are going to go to the intercostal muscles. Here on the top on the left, you could just see the two plexus, cervical plexus C1 through C5, and brachial plexus C5 to T1. Here's the phrenic nerve. Here's the axillary nerve, musculocutaneous. So cervical plexus C1 to C5, phrenic nerve is C3, 4, and 5. It keeps the diaphragm alive. When there's damage to the cord above C3, it causes respiratory arrest. So what's above C3? Above C3 is C1 and C2. What part of the brain is protected by C1 and C2? That's going to be the medulla oblongata. And in the medulla oblongata, we know it's cranial nerve 10. It's actually 8 through 12. Cranial nerve 8, 9, 10, 11, and 12. But cranial nerve number 10 is the vagus nerve. In the medulla is also the cardiovascular center and the respiratory center. So when there's damage to C1 and C2 or damage to the medulla, it can cause respiratory arrest. So if there's some sort of traumatic delivery during birth and there's excessive force, there's typically anywhere from 60 to 90 pounds of pulling on a baby's neck. That's pretty significant. It's enough at least to create a subluxation of the atlas. And subluxation of the atlas, if there's any type of interference there, you're looking at 8, 9, 10, 11, and 12 cranial nerves and plus heart and lungs, digestive organs, urinary, bowel movements. Babies, you look at the number one medication that babies are on, they're antacids. Babies can't hold down food many times, and that's because cranial nerve 10 is involved in regulating the tone of the sphincters between the esophagus and the stomach, okay, that lower esophageal sphincter. There was a prominent German physician by the name of Gottfried Gutmann, and he autopsied 1,000 babies that died of SIDS, that's sudden infant death syndrome. And what he found was that in 100% of the cases, in 1,000 babies, they all had what he referred to as atlantoaxial instability. And atlantoaxial instability means that there's some sort of instability between C1 and C2, which means that there's going to be subluxation at the level of the medulla. So now when you look at, well, what symptoms can that cause to a baby, you just have to look at, well, what does the medulla control? And what cranial nerves originate at the level of the medulla? That's cranial nerve 8, 9, 10, 11, and 12. 8 is for hearing and balance. So how many babies traumatically are born deaf as a result of that? Cranial nerve 9 and 10, this is parasympathetic, especially 10. Right? 9 is glossopharyngeal for swallowing, the muscles of the throat, and parotid gland is controlled by 9, and the sense of bitter to the back of the tongue is cranial nerve 9. 10 is the vagal nerve, which is, all pretty much 90% of the internal organs are vagal nerve. 11 is for the trapezius and the SCM muscle, and 12 moves the tongue. So very, very important. So if there's damage above C3, it can cause respiratory rest, it can cause cardiovascular issues, pretty serious stuff. And that's why all babies should always, always, always be checked after delivery for subluxation of the upper cervical spine. All 3 of my kids were checked immediately after delivery, and I have so many babies and young kids that are part of our practice as a result. And you heard me say in one of the earlier videos that I have 4 generations of family members in my office, several families of 4 generations, it's pretty amazing. It really is. So here's the cervical plexus. We said it's C1, C2, C3, C4, and C5. But from here, C3, 4, and 5 keep the diaphragm alive. There's the phrenic nerve. Okay? Not that the others aren't important, but this one is extremely important. Let's look at the brachial plexus here. Now, the reason why I really like this picture is because it shows how they originate in the neck. You could see that it goes underneath the clavicle. Now, sometimes there is a cervical rib that can get in the way here. That happens in a certain percentage of people. And it can compress the brachial plexus and sometimes the subclavian artery. And then these nerves, you can see they go all the way down to the fingertips. So here's the axillary nerve, musculocutaneous, radial, median, and ulnar. Those are the 5 terminal branches of the brachial plexus. So the entire upper extremity is controlled by the neck. So if someone is experiencing pain, numbness, and tingling somewhere in the hand, well, maybe the problem is in the hand, but remember, when you step on a dog's tail, it barks at the mouth, which is all the way at the other end. So many times you could be stepping on the tail, which is compression here at the neck, and it can refer all the way to the other end. And many times there is mistaken carpal tunnel syndrome because they have numbness in the fingers when the numbness is not taking place by a compression by the carpal bones in here, but the compression is taking place by a subluxation in the neck. Okay, and it doesn't have to be by bone. It doesn't have to be by bone spurs or discs putting pressure. You can actually have muscle, which is soft tissue, because in the neck there are scalene muscles that go in this direction, the scalenes, so that those tight neck muscles can compress it. And then going from the coracoid process, which is here, to ribs 3, 4, and 5, which is here, you have pec minor. So you can have pec minor syndrome or scalene syndrome. These muscles can compress the brachial plexus, creating a condition called thoracic outlet syndrome. And this individual will typically have dermatomal issues down here, the medial side of the forearm, the pinky, and the ring finger. And what dermatome would this be? This is here, it's the C8 dermatome, and then right here at the elbow, it's the T1. C5 is here, that's the C5 dermatome. C6 is here, including the thumb and the pointer finger. That's all C6 controlled dermatome. Okay, so we'll put C6 here. And then C7 is the birdie. C7 is the middle digit. We'll make 7 here. So we have C5 near the deltoid, the lateral arm. C6 near the brachioradialis and including the thumb and the index finger. That's the C6 dermatome. C7 is the birdie, the middle digit. C8 are the last 2 fingers, including the medial forearm. And then the medial elbow is T1. Okay, so when someone has thoracic outlet syndrome, it affects the lower end of the brachial plexus, the C8 and T1 nerve roots. Here's another good picture of the brachial plexus from C5 to T1, passes superior to the first rib, but under the clavicle. The axillary nerve controls the deltoid and teres minor. The musculocutaneous nerve is primarily elbow flexors, like the B's, the biceps brachii, the brachialis. The radial nerve is all the shoulder and elbow extensors and wrist extensors and most of the finger extensors. The median and ulnar nerve are the flexors of the wrist and the hand, and the median nerve does the majority of them. The median nerve does the majority of them. The ulnar nerve only does 1.5 muscles on the wrist flexor side. One of the muscles is the flexor carpi ulnaris, and then the half would be the half to these 2 fingers, the 4th and 5th digit, and that would be called the flexor digitorum, digits, right? Flexor digitorum profundus. The flexor digitorum profundus goes to digits 2, digits 3, digits 4, and digits 5, but the ulnar nerve is going to be controlling these 2, which is on the ulnar bone side. Okay, really good illustration of the brachial plexus, and it really does look like this. I remember doing human dissection myself many, many years ago when I was in school, and when we dissected the neck of the human body, we would have our book out. Back then we used a book by Frank Netter, and Frank Netter was a physician who drew out everything by hand, and it looked just like this. You know, we always used to say, well, you have to find the M at the end, and when you find the M, we know that we're looking at the end of the brachial plexus, and this was the M that we would see. Let me change the color. Let's make this green. Nope, let's make it blue. So this, 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 and this. That's the M that we would find. So you can see the musculocutaneous, you can see the radial, we can see the ulnar, and then there's the axillary. Okay. A lot of other nerves here that are important. I mean, lateral pectoral, and there's a medial pectoral for the pectoralis, major and minor muscles. When some of these nerves get damaged, they lead to certain conditions that are obvious that you've probably have all seen at some point in your life, and you just didn't know what was going on with the individual. Wrist drop is damage to the radial nerve. Claw hand, also known as bishop's hand, is damage to the ulnar nerve. This is ape hand. Ape hand is median nerve palsy, and that's atrophy right here in that thenar pad. And then they have no function of the thumb. And what separates us from the apes and the monkeys is that we have the ability to have the opposable thumb, whereas they don't. And then there's winging of the scapula, which is where the vertebral border starts to wing away, kind of flares out, and that's due to weakness to the serratus anterior. So when I teach my students this, I usually say, just remember Dr. Kuma. So Dr. Kuma, the D is for drop hand, that's radial nerve weakness. The C is for claw hand, that's ulnar nerve weakness. The A is for ape hand, and that's median nerve weakness. So Dr. Kuma. And then you can also remember with the winging down here, you can remember the mnemonic SALT. S-A-L-T. SALT is S-A is for serratus anterior muscle, and L-T is the long thoracic nerve. So when the long thoracic nerve gets weak, serratus anterior becomes affected, and you get winging of the scapula. Very commonly seen in young children up until the ages about 6 or 7. If you ever look at a young boy or young girl from the back at the beach or at the pool, you see that both vertebral borders of the scapula always wing away. It's not until that muscle really develops that it's held flush against the spine. Wrist drop, very commonly seen from birth trauma. When the radial nerve gets damaged, remember the radial nerve's job is to extend the wrist. So if you can't extend, then all of these muscles on the bottom are strong. These are the wrist flexors, and the wrist is held in flexion without any antagonizing opposition of the extensors. In terms of sensory distribution, we have the radial, ulnar, and median nerve, okay, and they control different areas. So the first, the second, the third, and half of the fourth is the median nerve innervation. And the median nerve also does the same 1, 2, 3, and half of the ring finger on the dorsal side, right? This is anterior and this is posterior. The only difference is on the anterior, it's pretty much all of the first, second, third, and half of the ring. But on the dorsal side, it's just the fingertips. The radial nerve on the dorsal side does the other 1, 2, 3, and half of the fourth, okay? And then the ulnar nerve is the other half of the ring finger and the pinky on both sides, okay? It's the other half of the pinky and the fifth digit on both anterior and dorsal side. When someone has carpal tunnel syndrome, that involves the median nerve. And then when the median nerve gets compressed, this is the pattern of distribution where they get typically lightning pain really like lightning pain to the first, the second, and half of the third. Okay. Here's the lumbar plexus and the sacral plexus. The lumbar plexus you can see in the upper part of the lumbar spine. The sacral plexus is, you can see, it's part of the sacrum over there. And the sacral plexus is from L4 to S4. And if you look at the nerves that we have associated, that sciatic nerve is the big one of the sacral plexus. I also want you to take a look right here where you have lumbar plexus, L1 to L4, and you can see the femoral nerve. The femoral nerve does sensation to the thigh, but the femoral nerve also controls the quadricep muscles. And the obturator nerve controls the adductors. Adductor longus, adductor brevis, and adductor magnus. Here, you can see L1, 2, 3, and L4, and you can see the green femoral nerve. You could see the obturator nerve. Those are the biggies, the femoral and obturator, and the lateral femoral cutaneous. That's the one that's involved with tight belt syndrome, or having something compress the anterior thigh by maybe having a tool belt, or a police officer with the gun and the nightstick. It's common. I've seen it so many times. The sacral plexus, L4 to S4, sciatic nerve is the biggie. Okay, sciatic nerve is the big one here. This plexus is anterior to the sacrum. So you can understand why many women during pregnancy end up coming to me in the office to get fixed, because they end up with sciatica. Look at where the sacral plexus is. It's anterior to the sacrum. And what do you think is hanging out right in here? Baby. Okay, so you can understand also how challenging it could be for women if they're in labor and they're trying to give birth while they're lying on their back, because look at where the 8 to 10 pounds of baby is pressing up against, lumbar and sacral plexus. Is it no wonder, 70 to 80% of births are C-section? It's because the woman is having so many challenges and difficulty in pushing a baby out when she can't generate the muscle contractions because the nerves are being impeded. Great view of the sciatic nerve there. You can see that. So I want you to see that. Let's take a look here. Here's the sciatic nerve, and you could see where the contributions are coming from. Here, here. So what do you think the person can experience if this disc starts to push out and it hits that nerve? Or if the person has arthritis and there's a bone spur growing off that bone that jabs that. Or the vertebra misaligns a little bit, hitting that nerve. Or this disc starts to push out. Or if the sacrum itself starts to tilt. What's going to happen if that has either an anterior pelvic tilt, or has a posterior pelvic tilt, or a lateral pelvic tilt? All of these deviations can affect the orientation of the sciatic nerve. So here, again, you can take a nice look at the nerve. You can see how large it is, but you can also see the two tones of green here. So the sciatic nerve is two nerves that come together. It's made up of the common peroneal nerve, and it's also made of the tibial nerve. These up here, the superior gluteal and inferior gluteal, that goes to to the gluteal muscles, gluteus minimus, medius, and gluteus maximus. And where do you think the nerve to the piriformis goes? The piriformis muscle, right? Let's take a look at the pathway here. Okay. So from the posterior view, here's the sciatic nerve. You can see it coming on down. And right at the back of the knee, right here, you can see that there's a fork in the road, right? This is where it splits into the two nerves that made it up. One is the tibial nerve, which follows right down the back of the tibia this whole way. This is the tibial nerve. And the other one, right over here, it splits into the common peroneal. Okay? Now the common peroneal, anything with the name common, is going to split. So the common peroneal, let me change the color here. The common peroneal is going to split into a deep peroneal, which goes anterior. So we can see it here on the front. And then the superficial peroneal, which stays on the lateral side of the leg. Now, most of us have had this problem when you sit with your legs crossed, right? This leg, your right leg, if you're sitting with your right leg crossed over your left, there's compression that takes place right there. So that superficial peroneal nerve can get compressed, and then what happens? Your foot goes numb, doesn't it? You get that paresthesia, that abnormal sensation to the foot. The deep peroneal nerve, this one here, the deep peroneal nerve, goes to all of your anterior compartment muscles of the leg. And the anterior compartment muscles of the leg are all dorsiflexors. Dorsiflexors lift the foot up in this direction, almost as if you're walking on your heels. Plantar flexion looks like this, stepping on your tippy toes. So the deep peroneal nerve primarily comes from L4. So I always remember L4 is your dorsiflexor, primarily tibialis anterior. L4, dorsiflexor, tibialis anterior. S1 does plantar flexion and hip extension. S1 is plantar flexion and hip extension. L5 is leg to the side. L5 brings the leg to the side. L5 brings the leg to the side, which is hip abduction. Okay. Okay, so now the other thing that I want to point out to you, let's just clear this out for a second. Come back here. So look at where this sciatic nerve comes out of. Remember this right here? The greater sciatic notch? And then there's a lesser sciatic notch from osteology. So you can understand that if this pelvis is not even, if it's tilted, one leg is shorter than the other, or there is just subluxation and tilting of that, then the orientation of that greater and lesser sciatic notch changes. That alone can put pressure on the sciatic nerve. And then also keep in mind that there is a muscle over here that's called the piriformis that goes from the anterior sacrum to the greater trochanter. And it's an external rotator. It goes like this. So a tight piriformis can compress the sciatic nerve. It's called piriformis syndrome. You can have subluxations of the spine that can cause sciatica. You had herniated discs that can cause it, bone spurs that can cause it, even flat feet. If you have flat feet or pes planus, the talus bone drops inferiorly, and then the tibia rotates medially, and then the femur rotates medially, And again, if this was the flat foot and it dropped down, then the pelvis and sacrum tilt on that side. Okay, and that puts a lot of pressure with all that medial rotation, puts a lot of pressure on this muscle called the piriformis, causing sciatica. So not only can lateral tilting of the pelvis can cause it, but either an anterior pelvic tilt that gives the person like that bubble butt type of appearance, or posterior pelvic tilting, which gives the flat butt, like where's his or her butt? I don't see a butt, right? So both of those can cause sciatica or sciatic symptoms. And when they do have sciatica, the pain can go down the back of the thigh. The pain can skip the thigh and it can just go to the back of the leg, or it can skip all of that and just go down to the foot. I've seen all of these distributions. Dermatomes, you've heard me mention this when we talked about the skin. Dermatomes is like a neurological mapping of the skin. And there is a cranial nerve 5 has a dermatome. And let's take a look at the dermatomes. There's a few different maps of it. So let's take a look. This is what I was drawing on one of those nerve charts. So here's C5 sensation, where you can feel C6. You can see it's the thumb and the index finger. C7 is the birdie. C8 are 4th and 5th digit. T1 is the inside of the elbow. And then T2 is PU, under the armpit. T4 is around the nipple region. And T9 or T10 is the belly button region. And then you have L1, L2, L3 to the knee. These are on diagonals usually. L1, L2, L3 to the knee. L4 down to the floor. L5, top of the foot, down the side here, lateral leg and top of the foot. S1 is the pinky toe, and S1 is underneath the foot as well. Notice there is no C1 dermatome. And these, don't really make too much sense in this position. However, if you can Google this and find the human in a quadruped form, like on all fours, then it makes sense from here down to here. Okay? In anatomical, it kind of looks a little funky, but on hands and knees or hands and feet, it'll make perfect sense. Here's another one that I really like. I like the lower extremity one here better, where it's L1, L2, L3 to the knee, L4 down to the floor, L5 to the top of the foot here. S1 is kind of like a mirror image to L4 in the leg. S1 is the outer leg and outer pinky toe and the bottom of the foot. Okay. And notice, what is the face? The face is cranial nerve number 5. Here is shingles. You can see that this is affecting the dermatomes here. Maybe here is like a little bit of the ribs, but also maybe a little bit like intercostal nerves, but these are dermatomes. Okay. Neuritis is an inflammation of a nerve. Can be caused by injury, can also be a vitamin deficiency. We know that, or toxicity even. We know that B6 deficiency or toxicity can cause neuritis. Shingles, we know, is an infection of a peripheral nerve by the chickenpox virus. It can cause pain, skin discoloration. You get these blisters. Polio is a viral infection of the anterior horn cells, so it causes this motor neuron death, and death usually occurs from either heart failure or respiratory arrest. Sciatica is the irritation of the sciatic nerve. Can be by misaligned vertebrae, arthritis of the spine, disc bulges, tilted pelvis, piriformis, even scoliosis can certainly be responsible for that. Decreased curvatures, like military spine, or increased curvature, just like a hyperlordosis, and so can pes planus, which is flat feet. We talked about carpal tunnel syndrome. It's 3.5 fingers, which is the first, second, third finger, and then half of the ring finger. Two tests that typically can be done conservatively. One test is called Tinel's sign, which is simply taking a finger or a reflex hammer and tapping over the volar ligament of the wrist, or where the transverse carpal ligament is, which is on the anterior side, right where the carpal bones are. And if you tap there and they get lightning pain to those 3.5 fingers, then it means the median nerve is being compressed somewhere in the carpal tunnel. Fallon's test is when you take both of your hands and you fold them in so that the dorsal surface palms are touching each other. So basically your wrists are hyperflexing against one another. And if that creates shooting pain to 1, 2, 3.5 fingers, that could be indicative of carpal tunnel. Needle EMG is like the gold standard. They basically, let me see if I can draw this for you. Oh, sorry about that. Let's see if I can go back. Okay, let's go to this slide here. When we talked about carpal tunnel, see if I could draw this a little bit. So let's see, I'm going to try and draw a crude picture. There's the thumb, first, second, ring, pinky, wrist. Really bad drawing, but let's just say here's 1, 2, 3, 4 carpal bones, and then another 4, 1, 2, 3, 4 carpal bones. So those are the 8 carpal bones, 4 in the proximal row, and then we have 4 in the distal row, right? Okay, and now let's say from here, from these 2 bones to these 2 bones is the volar ligament, or the transverse carpal ligament, also known as the flexor retinaculum. And the whole idea of this, think of it as a watch band, the whole idea of that ligament is that it's designed to hold down all of the flexor tendons that can go through here that go to the, to the fingers, like flexor digitorum superficialis that goes to these fingers, and then there's flexor digitorum profundus that goes all the way down to the end. So all of these muscles go through the carpal tunnel. So it's the space, if I were to do it this way, 1, 2, 3, 4, and I draw it like this, and this is the flexor retinaculum. Okay, so this is the floor, and this is the roof of the carpal tunnel. The floor are the carpal bones, and the roof is the volar ligament, or the flexor retinaculum, or the transverse carpal ligament. And what goes through the tunnel are 1, 2, 3, 4 tendons, which were the flexor digitorum profundus. That would be the ones that go all the way into the fingertips. And then we have another 4, 1, 2, 3, another 4, which is the flexor digitorum superficialis. So those would be the flexor digitorum superficialis tendons. These were the flexor digitorum profundus. Okay, so now the person's using their fingers a whole lot. They're a massage therapist, they're a chiropractor, they're typing all day, they're a mechanic, some sort of occupation in which they're using their uh, their fingers all the time. And as a result of overuse of the fingers, what's going to happen to the tendons and the muscles? They're going to increase. Oh, by the way, I'm just going to put a little, I'll put an X here. And this X is going to be, or the star that I'm going to make is going to be the median nerve because it goes through that tunnel. Now, what happens when you use these muscles over and over? What happens to muscles when they're exercised? Oh, they hypertrophy. They get thicker. And what happens to the space in the carpal tunnel if these muscles and tendons get thicker? Oh, the space in the tunnel gets much less. And what's going to happen to that median nerve? It's going to get compressed, and that's what carpal tunnel is. So what they do as the gold standard, they can put one needle here on this side of the retinaculum, and then they put another needle here. And then they go zap, they send an impulse. And they're measuring how long it takes from the impulse to go from A to B. Now let's say it should take 1 second, just for simplicity. If it should take 1 second, but when they zap it, it takes 3 seconds, what type of assumption can we make? Well, there has to be some traffic jam here in the tunnel that's slowing down the impulse from here to here. Okay, now usually there's a bone in here that subluxates, and it's called the lunate. The lunate bone can subluxate. Okay, if it should take 1 second to go from A to B, and it does, but they're still experiencing pain or numbness or paresthesia or tingling into the fingertips, then the compression is happening someplace proximal to the carpal tunnel. So then they'll look at the elbow. It's because between the proximal head and the deep head, or the pronator teres, is the median nerve that innervates through that. Okay? Okay. So that's the needle EMG is the gold standard. Okay. TOS, thoracic outlet syndrome. Let's go back here. TOS we mentioned a little bit earlier. It's when the lower end of the brachial plexus and or the subclavian artery is being compressed by the scalenes or pec minor. So the lower end of the brachial plexus is C5 to T1. What's the lower end? The lower end is the C8 and T1 nerve root. So now where's the dermatome of C8 and T1? So we got to go back here, and we can see that C8, let me go to this one here, C8 is the pinky and the ring finger, and T1 is the elbow. So that's the symptoms. The symptoms are felt all along the medial aspect of the forearm and the ring finger and the pinky with TOS, okay? So now, let me get to that again. So there's a few tests that one can do to try and differentiate. Is the problem coming from the scalenes? That would be Adson's test. Or is the problem coming from pec minor? Then they would do the Wright's test. The symptoms are the same with either. It's just a matter of what's doing the compression. If it's in the neck, let's say I'm taking the person's pulse on their left hand, and I have them turn their head to the left. I have them look up in the sky, and from their mouth, I have them take a deep breath. I have them take a deep breath because the scalenes are an accessory muscle for respiration. They look up, they take a deep breath, and all of a sudden, I feel their pulse diminish. Now I know the scalenes are compressing the subclavian artery. If the pulse remains the same and it doesn't change, but they get numbness and tingling down the medial aspect of the forearm and the pinky and ring finger, then I know the brachial plexus or the lower end is being compressed. If that's negative, then I take their pulse and I raise their arm by hyperabducting it above their head. I feel the pulse. If the pulse remains the same and it doesn't diminish, then the subclavian artery is fine. But if I raise the arm above the head and they say they're feeling numb and tingly down the inside of their elbow or down the pinky or half of the ring finger, then we know that it's the pec minor doing the compression. Many of you have actually had this TOS. If you're sleeping on your stomach with your hand under the pillow and your head turned and you wake up and your hand is numb, that's thoracic outlet syndrome. But when your arm is under the pillow, that's the pec minor syndrome. But by having your head turned, that's the scalenes. So it doesn't differentiate which one it is. It just tells you it is TOS. Okay? All right. We hope you enjoyed that lecture.